All right, jumping right into it. We've got a request to go deep on unstable angina, especially for those of you working in the ER.
Yeah, a really important one to have a handle on.
We're going by the book, using those 2023 European Society of Cardiology guidelines, the gold standard when it comes to acute coronary syndromes.
Can't get much better than those.
This deep dive is all about giving you a super clear breakdown of unstable angina. Perfect if you need to brush up on the latest or, just want to be extra prepared for when things get hectic in the ER.
Absolutely. Knowledge is power, especially in our line of work.
So first things first, let's define unstable angina. I feel like it's one of those terms everyone's heard, but maybe not everyone can give a precise definition.
You're right, it gets thrown around a lot. But in a nutshell, unstable angina, UA for short, is what happens when your heart isn't getting enough oxygen-rich blood.
And the culprit there is.
Usually it's narrowed coronary arteries.
Okay, that makes sense. But what makes it unstable exactly?
It's all about the unpredictability. You see, symptoms can come and go without any real warning.
That definitely sounds like a high-stakes situation for everyone involved.
For the patient, of course, but also for us in the ER.
So how do we distinguish UA from, say, other conditions that cause chest pain? What are those unique telltale signs?
Well, with unstable angina, the key is a pattern of increasing chest pain. It might be happening more frequently, or maybe it's lasting longer, or even occurring with less exertion than before. And here's the kicker. It doesn't usually cause the kind of heart muscle damage that show up on a typical troponin test, at least not right away.
So not a full-blown heart attack, but definitely a warning sign. And you mentioned troponin tests. Are those still relevant when we're talking about unstable angina?
Absolutely, but with a bit of an upgrade. We now have these high-sensitivity cardiac troponin assays, HSCTN for short.
HSCTN, got it.
And these tests are incredible. They're so sensitive that they can pick up on the smallest amounts of heart muscle damage.
Wow, really?
Yeah, it's a game changer because we get a much earlier and more accurate view of what's going on with the heart.
So even if UA isn't causing a ton of damage initially, these HSCTN tests can still detect those subtle early signs.
Precisely. The 2023 ESC guidelines even came up with specific algorithms, the ESC 0H1 hour and 0.2 hours, based on how these HSCTN levels change over time.
Now you've got me curious. Algorithms. What are those all about and why are they useful in the ER?
Think of it this way. You're not just looking at a single HSCTN level. You're looking at the trend, how much it rises or falls over the first hour or two.
So the dynamic is key.
Yeah, if there's a significant change up or down, that really impacts the probability of a myocardial infarction. These algorithms let us quickly assess that change and get a much better handle on the level of risk.
It's like taking a video instead of a single snapshot, which makes total sense in a busy ER setting.
Exactly. You need to act fast.
Now let's talk about who's at risk for developing unstable angina. Who should we be watching out for?
A lot of the usual suspects are in play here. Smoking, high cholesterol, diabetes, high blood pressure, family history, and of course, age.
Right, the usual suspects.
But there's one thing I really want to stress. It's plaque rupture. That's a huge factor in unstable angina.
Plaque rupture. Break that down for me.
Okay, imagine you've got plaque buildup in those coronary arteries. Think of it like rust in a pipe.
Okay, I'm following.
Now, if a chunk of that rust breaks off, it can suddenly block the flow.
So it's like a sudden blockage.
That's pretty much what happens with plaque rupture, and that's when unstable angina can hit.
Makes sense. So anyone with lots of plaque buildup or, unstable plaques is at higher risk.
Exactly. And things like recent cocaine use or even recent surgery can also tip the scales.
So anything that stresses the heart or messes with blood flow.
Right. But remember, sometimes it's not always black and white. We don't always see those risk factors.
That's so true. So let's say someone comes into the ER. What should we be looking for? How does unstable angina actually present?
The classic sign is chest pain. Often it's described as this pressure, tightness, or a squeezing sensation. But here's the tricky part. That pain can radiate.
Radiate? Where to?
You might see it going to the arms, jaw, back, even the shoulders.
Doesn't that sound a lot like a heart attack?
It can be very similar, which is why we need to be thorough. Ask about the pain, when it started, what makes it better or worse, any other symptoms going on at the same time.
What kind of symptoms should really make us worry?
Well, if you see shortness of breath, nausea, sweating, dizziness, or if the patient has this feeling of impending doom, that's when you really need to pay attention.
I do.
And don't forget, some patients, especially older adults and women, might not have the classic chest pain at all. It can be very atypical.
So we need to be really sharp with our history taking, looking at the whole picture. But once we think it might be UA, how do we confirm that diagnosis quickly and accurately, especially in a busy ER?
The ESC guidelines are very clear on this one. Electrocardiogram, ECG, within 10 minutes of first contact.
ECG first and foremost.
It helps us rule out other things and also pick up on any patterns that suggest UA.
So what kind of patterns on the ECG would point us toward UA?
You might see ST segment depression or maybe T-wave inversions, but the key thing to remember here is that UA is about reduced blood flow, not necessarily massive heart damage.
Okay, so it's different from a full-blown heart attack.
Right. The ECG could even be completely normal, so we have to put it all together, the ECG findings, the clinical presentation, and of course those high-sensitivity troponin results.
All right, those HSCTN results and the algorithms you mentioned before, sounds like they play a big part in how we triage patients with suspected UA.
Exactly. If that initial HSCTN level is really high, or if we see a rapid increase,
A red flag.
that's a high-risk situation, and we need to jump into action right away.
So it's about connecting the dots, the history, the ECG, and those troponin trends, like solving a puzzle.
Exactly. We were just talking about those high-sensitivity troponin levels and the ESC algorithms for assessing risk.
Yeah, that risk stratification is key.
Absolutely. It's really where things get serious in the ER. If the troponin level is low and stable, well, maybe we can take a more conservative approach.
Okay, makes sense. But what if it's high or rising rapidly?
That's when things get really interesting, and we need to move quickly.
Interesting is one way to put it. Sounds like it's time for urgent intervention. What are our immediate steps when someone comes in with unstable angina?
The first thing is always stabilize the patient.
Stabilize, so we're talking.
Supplemental oxygen if they need it. Make sure we address any pain they're having. And of course, aspirin if they haven't taken it already.
Aspirin. Seems simple enough, but it's a cornerstone of cardiac care. Why is it so crucial in those initial moments of unstable angina?
Because it works. Aspirin's great at preventing blood clots from forming, which could make that blockage in the coronary arteries even worse. It's such a simple intervention, but it can make a huge difference.
Got it. Oxygen, pain relief, aspirin. What's next in our arsenal?
We're going to bring in the antithrombotic therapy. These are medications designed to prevent clots and improve blood flow.
Antithrombotic therapy. Big word, but important stuff.
The exact drugs and dosages, well, those depend on the patient, their risk factors, how they're presenting, all that. But we can break down some of the key players.
All right, let's get into the details of these medications. Let's start with the antiplatelets, the ones we use every day in the ER.
So one we use often is clopidogrel. Generally, it's well-tolerated, effective at reducing that clotting risk. But we also have newer antiplatelet drugs like prasugrel and ticagrelor. These can be even more powerful in certain situations.
Prasugrel, ticagrelor, I've heard of those.
Yeah.
Are those always the preferred option over clopidogrel?
Not always. They are stronger, but they also come with a slightly higher risk of bleeding. We have to take that into consideration. Prasugrel, for example, we don't use that in patients over 75 or those who've had a stroke. Ticagrelor, on the other hand, can be a great choice for patients who maybe can't tolerate aspirin.
It's all about finding that right balance then. We need that strong antiplatelet effect, but we have to be mindful of those downsides. Are there ever situations where we absolutely should not use these medications?
You got it. It's all about weighing the risks and benefits for each patient. If they have active bleeding, a history of intracranial hemorrhage, or severe liver disease, then these antiplatelet drugs are off the table. And we always need to be on the lookout for drug interactions, especially with patients who are on multiple medications.
Oh, absolutely. Polypharmacy is a big challenge, so those interactions are always at the top of our minds. Now, we've covered antiplatelets, but what about anticoagulants? How do they fit into the unstable angina picture?
Anticoagulants, those are critical for preventing clot formation, especially during that acute phase of unstable angina. A good example is heparin.
Heparin. Yeah, that's a familiar one.
The ESC guidelines recommend using either unfractionated heparin or low molecular weight heparin, often called LMWH for most patients.
Unfractionated versus LMWH. That seems to be a common discussion point in cardiology. What are the practical differences for us in the ER?
Well, with unfractionated heparin, it's given intravenously, and you need to keep a close eye on the patient. LMWH, on the other hand, can be given subcutaneously, so we don't have to monitor as often.
So LMWH might be a little more practical in a busy ER where we're, juggling a million things.
That's exactly right. And then we have bivalirudin. This one's another anticoagulant that's often a good choice for patients who are undergoing PCI, that's percutaneous coronary intervention, or for those with a history of heparin-induced thrombocytopenia. That's a rare but serious complication.
Heparin-induced thrombocytopenia, yeah, definitely
Yeah.
something we want to avoid. We've got clopidogrel, prasugrel, ticagrelor, heparin. It's a lot to remember. Any tips or tricks you use to help decide which antithrombotic is the right one for the situation?
For me, it's helpful to think about risk stratification. If it's a lower risk patient, clopidogrel and a standard heparin regimen might be just fine. But if it's a higher risk patient, maybe someone undergoing PCI, then you might want to consider a more potent antiplatelet like prasugrel or ticagrelor and maybe bivalirudin for anticoagulation.
Risk stratification, that's a good way to simplify things. Now, are there other medications we need to be thinking about when we're managing unstable angina in those acute moments?
Nitrates are definitely important. Nitroglycerin, for example, can be really helpful for relieving that chest pain and improving blood flow. It does that by dilating the coronary arteries.
Nitroglycerin, yeah, classic.
And then we've got beta blockers like metoprolol. These can help slow down the heart rate and reduce the workload on the heart.
So nitrates for the pain, beta blockers to ease the strain on the heart. It all makes sense. Anything else we should have in our back pocket?
Sometimes we use morphine for pain control if nitroglycerin isn't working. But the guidelines are very clear. Be careful with morphine.
Oh, why is that?
Well, it can mask symptoms and even cause a drop in blood pressure, especially in patients who are already hemodynamically unstable.
Ah, right. So it's all about weighing the risks and benefits. We've talked about the initial presentation of unstable angina, the stabilization, and those all-important medications.
But that's just the first act. We still need to talk about longer-term management, things like revascularization procedures, and we also need to consider how we handle unstable angina in patients who have other health problems, those comorbidities.
Right. Real-world patients are complex. It's rarely just one thing.
You got it, and we're going to tackle all that in the next part of our deep dive.
We've covered so much ground already, from diagnosing unstable angina to those essential medications we use in the ER.
Right.
But we know our patients aren't textbooks, right? They often have a whole bunch of other health issues going on, so we can't just focus on the heart in isolation.
Right.
What are some of those special things we got to keep in mind when it comes to unstable angina, particularly in patients with other health conditions?
Comorbidities, yeah, they can really throw a wrench in things, that's for sure.
Yeah, for sure. Let's start with one that's pretty common. Chronic kidney disease.
CKD.
Yeah.
That one comes up a lot.
And it complicates things. The kidneys do so much, filtering waste, medications, the whole 9 yards. How does CKD specifically affect how we manage unstable angina?
The biggest thing is medication dosage. When those kidneys aren't working the way they should, it throws off how drugs are broken down and cleared from the body.
Makes sense.
We have to adjust those doses really carefully. Often we use that estimated glomerular filtration rate, the EGFR, to guide us.
Okay, EGFR, got it.
The good news is that the ESC guidelines, they're pretty detailed when it comes to dose adjustments. They cover all the major meds we use for UA, things like antiplatelets, anticoagulants, even some pain relievers.
Well, that's really helpful having those guidelines handy, especially when time is of the essence. What other challenges does CKD throw at us?
Well, patients with CKD, they're also at a higher risk for bleeding complications. So we got to be extra careful when we're using antiplatelet or anticoagulant therapy. It's always about balancing the risks and benefits, isn't it? We want to prevent clots, but we also want to avoid bleeding.
Exactly. That balance is so important. And what about contrast-induced nephropathy? That always jumps into my mind when we're thinking about angiography in patients with CKD.
You're right on the money. Contrast-induced nephropathy, that's a type of kidney injury that can happen after we use contrast dye. And we use that for procedures like angiography, right?
Right.
The ESC guidelines, they're pretty clear on this. Use the lowest possible dose of contrast and make sure the patient is well hydrated before and after the procedure.
So minimizing that contrast exposure, that's key.
In some cases, we might even think about other imaging options, like coronary CT angiography.
Okay, so lots to think about with CKD. Sounds like managing unstable angina in those patients requires a very careful approach.
Absolutely.
Okay, let's switch gears to another really common comorbidity, diabetes. How does that play into the unstable angina situation?
Well, diabetes is a big risk factor for heart disease in general, right?
Right.
Patients with diabetes, they often have more extensive coronary artery disease, and they're at higher risk for those complications that can come with UA.
So they're already starting off at a disadvantage. And we have to pay close attention to their blood sugar, I imagine.
You got it. Blood sugar control, that's absolutely essential, both in the short term and the long term.
Makes sense.
High blood sugar, it can actually worsen ischemia and make those bad outcomes even more likely.
So in addition to all the standard things we do for unstable angina, we add aggressive blood sugar management to the mix.
You got it.
Are there any specific medications that work particularly well for patients who have both UA and diabetes?
There are. The ESC guidelines, they actually recommend looking into some of the newer diabetes medications, things like SGLT2 inhibitors and GLP-1 receptor agonists.
Okay, those are the newer ones.
They're great because they not only help control blood sugar, but studies show they also have benefits for the heart. They can actually reduce the risk of heart attack and stroke.
Wow, so they kind of tackle two problems at once. That's incredible.
It's a big step forward for these patients, that's for sure.
Now let's talk about a real curveball.
Yeah.
Cancer. Managing unstable angina in someone with active cancer, that's got to be really tough.
It's a whole different ballgame, definitely more complex. These patients, they're already going through so much. They might be frail, they might have weakened immune systems, and the risk of both bleeding and clotting complications, well, it goes up.
That makes sense.
So decisions about things like revascularization or antithrombotic therapy, they get much more complicated.
Yeah, I can see how that would be a tough call. So it sounds like a really individualized approach is critical here. We need to consider the type of cancer they have, how far along it is, their overall health, what their goals are.
Exactly. And it often takes a whole team to get it right. The oncologist, the cardiologist, us in the ER, we got to talk to each other, make decisions together.
It's about that whole patient perspective, isn't it? Not just treating the unstable angina in a vacuum.
100%. And the ESC guidelines, they really emphasize that holistic approach. It's about patient-centered care.
That's a great point. It's not just about following algorithms. It's about understanding each patient's unique needs and what they want.
Absolutely. Shared decision-making, clear communication, respecting their wishes, that's how we get the best possible outcomes.
All right. So for all those ER docs out there listening, we've gone deep on unstable angina today. Diagnosis, treatment, those tricky cases with comorbidities, we covered it all. What's the one thing you want them to remember?
The most important takeaway is to never stop learning. Medicine is always changing. Unstable angina too. Stay curious, stay up to date, and always keep pushing to provide the best care for your patients.
Great advice. Thanks for joining us on this deep dive into unstable angina. We'll catch you on the next one with another fascinating topic. Until then, stay curious and keep those brains engaged.